Today, we are taking a monumental journey through pharmaceutical history. We're talking over 200 years of cardiac care.
That's right. Our subject is heart failure pharmacology, and our mission today is to really synthesize this incredibly dense foundational material.
It really is.
We're going to be tracking the shift from, treating symptoms with these dangerous, albeit effective plant extracts, all the way to today's multi-target molecular strategies that actually modify disease progression and improve survival.
And the whole story really starts back in the 18th century. The name that just dominates that period is digoxin. Before the modern era of medicine, these compounds, known as cardiac glycosides, they were the absolute standard for a failing heart. The hook here, for me, is the paradox that's sort of baked into their very function.
It's a wonderful paradox, and it's what gives the entire class its name. Cardiac glycosides have this remarkable property. It's a cardiac inotropic property.
Right. Let's break that down.
In the simplest terms, it means they increase the force and the efficiency of the heart's contraction, the squeeze, but they do it without causing a disproportionate increase in the heart's demand for oxygen.
That is the medical equivalent of getting a massive boost in horsepower without increasing the fuel burn.
Exactly.
And in a failing heart, which is already starving for energy, that effect is, well, it's priceless.
Precisely. And the discovery is a classic tale of traditional medicine meeting scientific rigor. It all started with the common foxglove plant, digitalis.
Tell us about that origin story. The history here feels almost as important as the mechanism.
Well, we have to travel back to 1785. And an English physician, William Withering, who was practicing in Birmingham. He published this seminal work on extracts from the foxglove.
And this wasn't a new discovery, really.
No, not at all. For centuries, traditional healers had used this plant, often with disastrous results because the therapeutic window is so narrow. They used it to treat dropsy.
Dropsy being that historical term for the profound fluid retention, the severe edema, the congestion that we now know is the absolute hallmark of congestive heart failure.
Correct. Withering was the first to systematically study it, to document the effects of the digitalis extract. He was able to deduce that the true benefit of the plant wasn't a diuretic action, but its ability to strengthen the heart's pump.
So it improves circulation, and that secondarily relieves the edema.
That's it. And for nearly 200 years, these cardiac glycosides were the standard of care.
And the most important molecule to emerge from this plant family, the prototype that, remains clinically relevant even today, is digoxin.
That one's derived specifically from the woolly foxglove digitalis lanata. And while other historic CGs like digitoxin or uabane have pretty much faded from clinical use, digoxin has endured.
Though its role has changed.
Oh, dramatically. As we'll see, its role in treating heart failure has shrunk in favor of modern drugs.
Okay, let's jump right into the core of the pharmacology then. You mentioned these are glycosides derived from plants. Let's explain why their structure matters so much. What are these compounds chemically made of?
The structure is, it's foundational to how it all works. A cardiac glycoside is composed of two primary sections. First, you've got the sugar part.
The glyco part of glycoside.
Exactly. One or more attached sugar moieties, like glucose or digitoxose. These sugars primarily affect the drug's solubility and its pharmacokinetic profile, so how the body absorbs it, how it processes it.
And the second part, the part that actually does the work.
That's the aglycone, also called the genin. This is the non-sugar portion, and it contains the steroid nucleus.
Right. I've seen the term cyclopentanohydrophenanthrene ring system.
It's a mouthful.
Yeah.
But what's important is that this large multi-ringed steroid backbone is critical because it mimics endogenous steroid structures. It lets it anchor securely into the target enzyme.
Okay, and what about that distinctive unsaturated lactone ring that's attached to the steroid nucleus?
Lactone ring, it's a 5 or 6 membered ring, and that is the chemical key. It is absolutely essential for the biological activity.
So without that ring?
The whole thing is a dud. It facilitates the binding of the glycoside to its primary target, the sodium-potassium ATPase enzyme. If you change the chemical orientation of that ring, or if you saturate it, the drug just loses its ability to increase contractility.
So the structure isn't just a label, it's a functional piece of machinery, almost like it's designed to mimic a natural steroid and dock perfectly into the pump.
That's a perfect analogy. And as you noted, digoxin is the standard now, while the others are sort of historical footnotes.
Why is that?
Well, digitoxin, from the purple foxglove, was used widely, but it had a much, much longer half-life, which made dosing even trickier, more dangerous. Uabane was a short-acting CG, and it's also no longer marketed. Digoxin's specific chemical properties have just made it the survivor.
Let's detail its pharmacological actions then, the dual benefits. We know action 1 is that positive inotropic effect, increasing the force of contraction. How does this clinically benefit the failing heart?
In a failing heart, the ventricles really struggle to generate enough tension to overcome the resistance of the arterial system, what we call the afterload.
Right.
Digoxin causes a significant dose-dependent increase in the force generated by the myocardial fibers. This isn't just a theoretical benefit, it's a massive functional improvement.
And what are the specific visible consequences of this improved squeeze on the cardiac cycle?
It creates a much more efficient cycle.
Yeah.
The period of contraction, systole A, is dramatically shortened.
So it's a quicker, sharper pump.
Exactly. And crucially, the period of relaxation and filling, diastole, is prolonged.
Why is that so important?
Because the failing heart often beats rapidly and inefficiently. Prolonging diastole gives the heart muscle more time to perfuse itself, to get oxygenated blood, and it gives the ventricles more time to fill adequately. That directly increases stroke volume and thus cardiac output against that high arterial impedance.
So it's a total mechanical optimization, more force, more filling time. But the second action is equally profound. You mentioned the electrophysiological benefits.
Yes, that's the vagomimetic or anti-sympathetic action. Chronic heart failure often involves this detrimental state of sympathetic nervous system overdrive. The body's constantly in fight or flight.
And digoxin helps calm that down.
It does. It helps restore a diminished vagal tone, and it actively depresses this damaging sympathetic overactivity.
This sounds like a systemic effect, not just a local muscle effect.
It is. The increased vagal influence combined with direct drug actions on the cardiac conduction system significantly reduces the heart rate. This is especially useful for conditions involving fast, chaotic rhythms originating in the atria.
Okay, let's focus on the nodes here. The SA node is the pacemaker, and the AV node is the gatekeeper to the ventricles.
Digoxin depresses the function and conductivity of both the sinoatrial, the SA node, and the atrioventricular, or AV node. This depression leads to an increase in the refractory period. That's the time the cells cannot fire again.
And by increasing the refractory period of the AV node,
you limit the number of rapid, chaotic impulses from the atria that can actually reach the ventricles.
So you're controlling the ventricular rate.
You are. And this ability to slow the ventricular response is one of digoxin's 2 most important modern uses.
We've established the effect of digoxin's stronger squeeze, slower rate. Now let's get into the cellular molecular heart of the matter. This is where the magic happens, and it all starts with blocking one of the most fundamental cellular machines, the Ne plus MAGIS-K plus ATPase.
Absolutely. The entire positive inotropic action pivots on this singular direct interaction. Digoxin selectively binds to a specific site on the extracellular face of the alpha subunit of the Ne plus MAGIS-K plus ATPase enzyme. You find it all over the myocardial fibers.
Okay, let's do a quick refresh on the normal function of this pump. It's not just a simple exchange, is it?
No, it's incredibly important. Normally, this pump maintains the steep electrochemical gradient necessary for life. It consumes ATP, energy, to actively transport 3 sodium ions out of the cell and 2 potassium ions into the cell,
creating this massive concentration gradient with way more sodium outside the cell.
Right, and that gradient is the energy source for countless other cellular processes.
And digoxin essentially jams the lock.
It acts as an incredibly selective inhibitor. When digoxin binds, it halts this active transport. The immediate primary consequence is that sodium ions are no longer efficiently pumped out. So sodium concentration starts to slowly but progressively accumulate inside the myocardial cell. That's step 1 of the cascade.
Okay, so the immediate target is sodium. But the ultimate goal is calcium accumulation to increase force. How does rising intracellular sodium translate into rising intracellular calcium? This is that fascinating aha moment.
This is where we see the ripple effect across cellular transport systems. The key connection is another transporter, the sodium-calcium exchange transporter, which is known as the NCX antiporter.
And its job is to fine-tune calcium levels.
Yes, by utilizing the energy stored in that sodium gradient we just talked about.
How does it use that gradient?
Well, in its forward mode, the NCX typically imports 3 sodium ions into the cell while simultaneously extruding 1 calcium ion out of the cell. This whole process is powered by the incredibly low concentration of sodium inside the cell, which creates this powerful driving force for sodium to rush in.
I see the problem. If digoxin has caused intracellular sodium levels to rise, You've fundamentally reduced the driving force that the NCX antiporter needs to effectively eject calcium.
Exactly. The low intracellular sodium concentration, which normally provides the energy sink for the antiporter, well, it's diminished. The NCX slows down dramatically. It becomes far less effective at clearing calcium from the cell.
So it's not directly boosting calcium, it's just preventing it from leaving.
A failure to properly export it, yes. This leads to a progressive and sustained accumulation of calcium within the cytoplasm, and crucially within the sarcoplasmic reticulum, or the SR.
So the heart muscle cells essentially become these little storage tanks for a higher baseline level of calcium than normal. How does that translate into the observable massive increase in contraction force?
Well, contraction relies on a phenomenon we call excitation-contraction coupling. When the heart cell depolarizes, a small amount of calcium enters the cell through specialized L-type calcium channels. This small influx is the spark.
And that spark ignites the stored reserves.
Precisely. That little spark triggers the opening of massive calcium release channels on the sarcoplasmic reticulum. These are the ryanodine receptors. This releases a huge proportional wave of stored calcium into the cytoplasm.
And since digoxin has ensured a higher baseline concentration of calcium is stored in that SR,
The triggered release is dramatically larger.
a bigger spark equals a bigger explosion.
In biological terms, yes. This massive surge of calcium means more calcium is available to bind to troponin C, which is the molecular switch that allows actin and myosin filaments to interact and generate force. More binding equals a significantly stronger, more forceful contraction. That's the positive inotropic action.
That is an incredibly elegant, if indirect, mechanism. Let's return to the electrophysiological consequences, linking this mechanism back to rate control and the potential for toxicity.
The beneficial electrophysiological actions, as we mentioned, are primarily centered on the AV node. The increased vagal tone and the direct cellular effects prolong the effective refractory period, or ERP.
Which is crucial for controlling the rapid, disorganized ventricular rate you see in atrial fibrillation.
Yes, but the very mechanism that increases the force, that increased calcium loading, is also the razor's edge for toxicity, isn't it?
It's the tightrope.
Absolutely. While therapeutic doses safely increase calcium stores, excessive inhibition of the pump at high doses leads to truly pathological calcium overload. This creates instability in the resting membrane potential.
And that instability manifests as those dangerous electrical hiccups we hear about.
Correct. The massive calcium overload can lead to the sarcoplasmic reticulum spontaneously leaking or oscillating, causing these small, aberrant depolarizations after the main action potential has ended.
Delayed after depolarizations, or DDADs.
That's them. And if these DIDs reach threshold, they can trigger new, rapid, and often fatal arrhythmias, like ventricular tachycardia or fibrillation. This is the hallmark of digitalis toxicity right at the cellular level.
That detailed look at the mechanism really clarifies why digoxin requires such meticulous management. If the therapeutic effect is a few nanograms per milliliter and the toxic effect is only slightly higher, the margin for error is, well, it's razor thin.
It is.
Let's unpack the pharmacokinetics and that narrow margin of safety.
The pharmacokinetics are indeed challenging. Oral absorption is decent, around 60 to 80%, but the critical number is the drug's half-life. It's approximately 40 hours.
40 hours. So what does that mean in practice?
It means if you start a patient on a standard maintenance dose, it takes roughly 4 to 7 days, that's 4 to 5 half-lives, to reach a steady-state concentration in the plasma.
That dictates a very slow, cautious approach to titration,
Right.
which is a big problem if a patient is acutely ill. And that 40-hour half-life points directly to a major clinical concern: elimination.
It absolutely does. Digoxin is excreted largely unchanged by the kidneys, primarily through glomerular filtration.
So if your kidneys aren't working well,
Any degree of renal impairment significantly prolongs that 40-hour half-life. The drug accumulates rapidly. If you, the listener, have a patient with declining renal function, the dose must be reduced drastically and monitored constantly, or you risk toxicity.
and let's just reiterate that low therapeutic index. The source is cited as 1.5 to 3, which means the toxic dose is barely more than the effective dose.
The therapeutic concentration window is exceptionally tight, 0.5 to 1.4 nanograms per milliliter. Anything above 2.0 NGMLA is usually considered toxic.
Wow.
We are talking about a difference of less than 1 nanogram per milliliter, separating therapeutic success from a potentially fatal arrhythmia. This is why drug-level monitoring, therapeutic drug monitoring, is not optional. It's mandatory.
Before the cardiac disaster strikes, there are usually warning signs, right? Often extracardiac ones. What are the first symptoms we should look for?
Clinicians are trained to watch for the non-cardiac signals
Yeah.
because they typically appear first, even though only about a quarter of patients on therapeutic doses experience them.
And what's the first system to complain?
The gastrointestinal tract is often the initial warning system. Anorexia, a profound lack of appetite, followed by nausea, vomiting, and abdominal pain.
And the CNS effects, especially those visual disturbances, they're quite specific to digitalis toxicity, aren't they?
They are very distinctive and often very disturbing for the patient. You see general CNS symptoms like fatigue, profound malaise, confusion, depression. But the classic visual disturbance is xanthopsia.
Xanthopsia.
The patient sees objects tinted yellow or sometimes green. They might see halos around lights. This is thought to be due to an effect on the Na plus K plus ATPase in the visual pathways.
Shifting to the most dangerous territory, the cardiac danger zone. Given that digoxin affects virtually all electrophysiological parameters, what are the most common and dangerous arrhythmias it induces?
Because of the mechanism that increased automaticity and the delayed after depolarizations, digoxin can cause almost any known arrhythmia.
That's terrifying.
It can be. We frequently see ventricular extrasystoles, which can progress to ventricular tachycardia or fibrillation, which is immediately lethal.
And there's one common presentation which is memorable, that coupling phenomenon.
Yes, pulsus bigeminis. It's a frequently observed, though not universally present sign. This is where every normal ventricular beat is followed immediately by a premature ectopic ventricular beat.
And that's the DADs firing off.
It represents that spontaneous triggered activity we discussed at the cellular level. We also frequently see partial or complete atrioventricular, or AV, block because the drug enhances vagal depression of the nodal tissue.
Okay, let's talk about the single biggest clinical potentiator of digoxin toxicity. It's a common complication in heart failure patients, especially those on diuretics.
That is hypokalemia, low potassium levels. This is the crucial interaction.
Why is this so important?
Hypokalemia significantly increases the potential for toxicity. Mechanistically, potassium and the digitalis glycosides compete for the exact same binding site on the Ni plus ATPase enzyme.
So if potassium levels are low,
Low extracellular potassium favors the binding of the digitalis glycoside to the pump. This means even a perfectly therapeutic dose of digoxin can suddenly become toxic if the patient becomes hypokalemic.
which is common if they're on loop diuretics like furosemide without adequate potassium supplementation.
Extremely common. Correcting even moderate hypokalemia is the most immediate clinical intervention for suspected toxicity.
So if a patient presents with toxicity, what's the immediate treatment protocol, especially if it's severe?
First and foremost, you stop the drug. That's step one. If the toxicity is caused or worsened by hypokalemia, K+ must be infused carefully, usually intravenously. If the patient has fast, unstable arrhythmias, antiarrhythmic agents like lidocaine or phenytoin are often used
Why those specifically?
because they're less likely to worsen AV block than some of the other options.
But for true life-threatening refractory toxicity, there is a specialized targeted antidote.
Yes, and it is a marvel of modern biotechnology. Digoxin-specific antibody fragments. They're often marketed as Digibind or Digifab.
How do they work?
These fragments are given IV, and they act like high-affinity sponges. They rapidly bind to the free digoxins circulating in the plasma, effectively pulling the drug out of circulation and away from the myocardial binding sites. It rapidly reverses the toxicity.
That's the definitive treatment for severe intoxication like ventricular fibrillation or hemodynamic collapse.
It is.
That wraps up our deep dive into the historical star. It's powerful, it's effective for congestion and rate control, but its management complexity is just immense. This challenge is precisely why medicine started looking for new strategies. We need to shift gears now and understand the disease state itself.
To appreciate the modern therapeutic revolution, you have to first appreciate the relentless, progressive nature of heart failure. It's defined by the state where the cardiac output is insufficient to meet the body's metabolic demands,
More.
or where those demands can only be met at the cost of dangerously high ventricular filling pressures.
The sources outline two fundamentally different ways the heart can fail, based on its ejection fraction. Let's clarify those categories.
We categorize HF functionally. The first is systolic dysfunction, which is known as heart failure with reduced ejection fraction, or HFrEF.
HFrEF.
Right. Here, the primary problem is a failure of the heart muscle to contract forcefully enough. The ejection fraction, the percentage of blood leaving the ventricle with each contraction, is typically reduced, often below 40%.
This sounds like a problem of muscle damage or chronic overload.
It is. The ventricles may become severely dilated and fail to empty completely. The classic causes are things that damage the muscle directly: coronary artery disease, a previous heart attack, and chronic dilated cardiomyopathy.
What about the second category, diastolic dysfunction?
That's heart failure with preserved ejection fraction, or HFpEF. In this case, the heart muscle contracts normally, meaning the EF is preserved, but the ventricular wall is thick and stiff.
So it can't relax.
The problem is impaired relaxation and filling during diastole. The heart cannot effectively load, so it cannot effectively pump.
So the HFrEF heart is too weak, and the HFpEF heart is too stiff.
That's a good simplification. HFpEF is typically a disease of chronic pressure overload, most commonly associated with long-standing hypertension, severe aortic stenosis, or hypertrophic cardiomyopathy. It leads to this concentric thickening of the ventricular wall.
Regardless of the mechanism of failure, the moment the cardiac output drops, the body initiates a series of compensatory mechanisms that, over time, become actively destructive. This is the vicious compensatory loop, and it's the key to the survival revolution.
This is the central tenet of modern HF treatment. These neurohumoral systems are acute survival reflexes, but when they're chronically activated, they actively accelerate the patient's death through maladaptive remodeling.
Okay, let's start with the renin-angiotensin system, or RAS. How does reduced output trigger this system, and why is the long-term consequence so catastrophic?
Reduced cardiac output means reduced blood flow to the kidneys. The kidneys respond by releasing renin, which triggers the cascade that culminates in the formation of angiotensin II.
And angiotensin II is a massively powerful player.
It is. Acutely, it causes intense vasoconstriction, increasing blood pressure, and it stimulates the release of aldosterone, which retains salt and water.
That seems like a good short-term fix. More volume, higher pressure.
It is acutely life-saving. Chronically, however, it's destructive. Angiotensin II and aldosterone are powerful signaling molecules that directly promote cardiac and vascular remodeling. They cause fibroblasts in the heart muscle to proliferate,
Leading to fibrosis.
scarring, and stiffness. And they cause myocyte hypertrophy, or abnormal thickening. This vicious remodeling just worsens pump function and contributes to both systolic weakness and diastolic stiffness.
So the RAS is turning the flexible muscular pump into a rigid, scarred organ. What about the sympathetic nervous system?
That system activates simultaneously. Reduced output signals the brainstem to increase norepinephrine release, leading to sympathetic overdrive. This increases heart rate and contractility to try and maintain output. Again, great for a crisis.
But terrible for a chronic state.
Absolutely. Chronic exposure to high levels of catecholamines is toxic to the heart muscle. It accelerates myocyte apoptosis, that's programmed cell death, which reduces the viable muscle mass.
So you're losing healthy tissue.
And furthermore, it constantly pushes the failing heart to consume more oxygen than it can possibly acquire, effectively driving the heart into energetic depletion and burnout.
It's forcing a deeply injured marathon runner to sprint indefinitely. Finally, what about the Frank-Starling mechanism?
Well, the Frank-Starling principle states that increased ventricular filling pressure stretches the muscle fibers, leading to a more forceful contraction up to a point.
Right.
In HF, the body uses this to maximize output by increasing volume retention. However, continually increasing volume raises central venous pressure and hydrostatic pressure.
Which leads to the miserable symptoms of congestion.
Precisely. This increased pressure forces fluid out of the capillaries and into the surrounding tissues, the lungs causing pulmonary edema and dyspnea, and the periphery causing peripheral edema or dropsy. While it tries to sustain output, it causes the very symptoms that define the disease.
So the fundamental realization that led to the survival revolution was that these three systems, RAS, sympathetic, and volume retention, are not friends. They are enemies in the long-term fight against chronic HF.
That's it, exactly.
Okay, this is the pivot point in medical history. Before the 1980s, we had digoxin and diuretics. We managed symptoms. Post-1980s, the paradigm shifted entirely to blocking the neurohumoral activation we just discussed. What was the core goal of this new approach?
The goal was simple yet revolutionary. Stop the heart from actively destroying itself via its own compensatory mechanisms. We shifted from improving performance to stopping decay.
And the first pillar of the survival revolution are the ACE inhibitors and ARBs targeting the RAS.
Yes, the foundational therapy.
How do they interrupt that RAS-driven destructive cycle? And what's the difference between an ACE inhibitor and an ARB?
ACE inhibitors block the angiotensin-converting enzyme, preventing the formation of angiotensin II from angiotensin I. This reduces systemic vascular resistance, the afterload, and it reduces aldosterone-driven fluid retention.
But the crucial part is the remodeling.
Critically, yes. By reducing angiotensin II, they interrupt the signaling pathways that lead to that ventricular remodeling, allowing the heart muscle to potentially reverse some of that destructive fibrosis.
They stabilize the organ itself. What about the ARBs?
Angiotensin receptor blockers, or ARBs, act slightly later in the pathway. They block the AT1 receptor, which is the site where angiotensin II exerts most of its detrimental effects. ARBs are absolutely essential for patients who cannot tolerate ACE inhibitors.
Why the intolerance? What are the key side effects that push a patient from an ACEI to an ARB?
The classic ACE inhibitor side effects are cough and rarely but dangerously angioedema.
The cough.
The cough is caused because the ACE enzyme also breaks down bradykinin. By inhibiting ACE, bradykinin levels rise, and that leads to this persistent, irritating cough in up to 15% of patients. ARBs don't affect bradykinin metabolism, so they bypass this issue entirely.
Making them indispensable alternatives for survival therapy.
They are standard for all HFrEF patients. They improve both symptoms and prognosis.
Moving to the second pillar, which for decades was controversial, beta blockers. For a failing heart, giving a drug that initially depresses contractility sounds like a huge medical mistake. What was the initial resistance?
The initial resistance was intense and, frankly, logical. Doctors argued, why give a drug that slows the heart and reduces contractility to a patient whose heart is already failing? The consensus was that beta blockers would precipitate acute decompensation.
But the paradox prevailed.
It did. The key insight was that while the acute effect is negative inotropic, the chronic effect of sympathetic overdrive is devastating. Beta blockers antagonize the long-term toxic effects of norepinephrine, the chronic wall stress, the increased oxygen demand, the acceleration of myocyte apoptosis, and the increase in renin release.
So by blocking the throttle, you allow the heart to rest and recover, promoting long-term survival.
Yes. The clinical trials showed sustained, dramatic reductions in both mortality and hospitalization rates. They even allow for the restoration of beta receptor sensitivity, which have been downregulated due to that chronic overdrive.
When initiating beta blockers, the strategy is extremely conservative, right?
Absolutely. This is the only way to manage that initial negative inotropic effect. They must be started at extremely low doses, sometimes 1/8 or 1/4 of the target dose, and gradually titrated up every few weeks to the maximum tolerated dose.
And you only stop them in an emergency.
You should only temporarily hold them during episodes of acute decompensation, where the heart needs every bit of sympathetic help it can get.
Are there different types, and does that matter in heart failure?
Yes, there are subtle differences. Selected beta-1 blockers like metoprolol just target the heart receptors. However, many clinicians prefer non-selective agents with ancillary properties, like carvedilol.
And what's special about carvedilol?
Carvedilol blocks beta-1, beta-2, and crucially alpha-1 receptors. The alpha-1 blockade causes vasodilation, which reduces systemic vascular resistance, and that contributes to afterload reduction.
So you get a multi-pronged benefit.
A benefit that is often considered superior in the HFrEF population.
Okay, the third pillar. Aldosterone antagonists, like spironolactone and eplerenone, why are these needed if ACE inhibitors already reduce angiotensin II, which drives aldosterone production?
This goes back to the concept of aldosterone escape. Even when the RAS is effectively blocked by an ACE inhibitor, the body often finds alternative pathways, non-ACE pathways, to increase aldosterone production over time. So aldosterone levels can creep back up.
And elevated aldosterone is intensely cardiotoxic, even separate from just fluid retention.
Exactly. Aldosterone promotes potassium excretion, increasing the risk of hypokalemia, and more critically, it's a primary driver of ventricular and vascular fibrosis, that stiffening and scarring of the heart muscle.
So adding a specific antagonist blocks that direct damage.
Yes, spironolactone and eplerenone block the mineralocorticoid receptor. They counteract sodium retention, prevent potassium loss, and importantly, reduce that detrimental fibrosis. They significantly reduce the incidence of ventricular arrhythmias and subsequent sudden cardiac death.
And where do they fit in the regimen?
They're used as add-on therapy for patients who have reduced EF and persistent symptoms, despite being on optimal doses of ACEI ARBs and beta blockers.
What's the key difference between spironolactone and eplerenone? And what do you have to watch out for?
Spironolactone is non-selective and can cause hormonal side effects, notably gynecomastia in men. Eplerenone is a more selective aldosterone antagonist and has a lower incidence of these side effects.
And the risk.
Regardless of which one you use, the paramount risk is hyperkalemia, too much potassium, because they are potassium sparing. You must closely monitor serum potassium and renal function, especially when they're combined with an ACE inhibitor.
The trifecta of ACE-IRB, beta blockers, and aldosterone antagonists is the engine of modern survival therapy. But patients still get fluid-logged and symptomatic, which brings us to the essential supportive drugs. Let's start with diuretics.
Diuretics are absolutely critical for managing symptoms, and they are used in almost every symptomatic HF patient. Their job is to alleviate the congestion caused by that Frank-Starling mechanism overload.
How do they do that?
They rapidly induce natriuresis and diuresis, removing fluid from the lungs, which relieves dyspnea, and from the extremities, which relieves peripheral edema.
What's the difference in use between the types? Loop versus thiazide.
For acute severe volume overload, we turn to high ceiling, or loop, diuretics like furosemide. They are extremely powerful and rapid in removing large volumes of fluid. For milder, chronic symptoms, a thiazide diuretic might be sufficient, or sometimes used in conjunction if resistance develops.
Here is the crucial distinction our sources highlight. They improve quality of life dramatically, but they are not disease-modifying.
Correct. Despite their powerful symptomatic relief, clinical trials have failed to demonstrate that diuretics alone improve prognosis or survival. They treat the symptom of fluid retention, but they don't reverse the underlying maladaptive neurohumoral progression.
And they can even be counterproductive.
They can. High-dose diuretics can induce hypokalemia, potentially activating the RAS, which is exactly what we're trying to block.
Next, targeted vasodilators. We use these to specifically reduce resistance on the heart.
Vasodilators are categorized by where they act. Nitrates, like isosorbide dinitrate, primarily cause venodilation. This increases the capacity of the systemic veins, pulling blood away from the heart. This reduces central venous pressure and ventricular and diastolic volume.
So preload reduction.
Exactly. It's invaluable for relieving acute pulmonary congestion.
And the other side of the coin, arterial dilators.
Drugs like hydralazine. These reduce systemic vascular resistance, which is the afterload reduction. By reducing the resistance the ventricle pumps against, the heart can empty more effectively, increasing the cardiac index.
And these are mostly for acute settings.
Hydralazine is often used intravenously for acute afterload reduction in critical care. But the sources specifically mention a unique chronic combination therapy.
Right.
The fixed combination of hydralazine and isosorbide dinitrate. This is a critical combination therapy shown to provide a long-term survival benefit even when added to the standard regimen.
And it works particularly well in one group.
Yes, this combination is especially noted for its profound efficacy in African American patients with severe HFrEF, making it a guideline-based recommendation for that population.
Let's talk about digoxin's modern diminished role. Where does it fit in today, given this survival revolution?
Its role has been refined entirely. Because it does not impact overall mortality, it is no longer a first-line therapy for chronic HFrEF.
So what do we use it for?
Its primary utility is now limited to chronic rate control. When a patient has atrial fibrillation or atrial flutter coexisting with heart failure, digoxin's vagomimetic effects are used to keep the ventricular rate under control. The positive inotropic action is simply a welcome secondary benefit.
Now for the cutting edge, starting with niche rate control drugs like ivabradine, this seems like a beta blocker alternative.
Ivabradine is unique because it's a pure heart rate reducer without the contractility depression of a beta blocker.
How does it work?
It works by selectively blocking the diaphia current, the funny current, in the SA node. Blocking this current reduces the slope of the diastolic depolarization phase, which effectively slows the heart rate.
So why would you use this instead of, or in addition to, a beta blocker?
It's approved for stable HF patients who are in sinus rhythm, have reduced EF, are already on maximum tolerated standard therapy, including beta blockers, but still have a resting heart rate greater than 70 beats per minute.
So it's an add-on to get that last bit of rate control.
It offers cardioprotective benefits by just reducing the speed of the heartbeat, without the associated negative effects on blood pressure or contractility.
What about the old, powerful sympathomimetic inotropics? Dopamine, dobutamine, are they obsolete?
Not obsolete, but their use is strictly limited to the acute emergency setting. They're IV infusions used to combat sudden catastrophic pump failure, like cardiogenic shock or acute decompensation, where immediate intratropic support is vital.
But no long-term role.
Absolutely no role in long-term chronic management. They just drive up oxygen demand and accelerate the detrimental sympathetic effects we've been trying to block.
Finally, we have to spend serious time on what many consider the biggest advancement since the beta blockers. The ARNI combination, sacubitril/valsartan. This involves the neprilysin system.
This is a genuine revolution in pharmacology. ARNI stands for angiotensin receptor neprilysin inhibitor. The drug combines the ARB valsartan with sacubitril, which is the neprilysin inhibitor.
And what is neprilysin?
Neprilysin is an enzyme that degrades beneficial endogenous hormones,
Which hormones are those?
primarily the natriuretic peptides ANP and BNP. The body produces these peptides in response to volume overload and ventricular stretching. They are inherently beneficial.
How so?
They promote vasodilation, inhibit sympathetic activity, and promote salt and water excretion. They are the body's own attempt to fight the damaging effects of the RAS.
So by inhibiting neprilysin with sacubitril, you dramatically increase the levels of these beneficial protective peptides.
Exactly. It allows the body's natural defense mechanisms, the natriuretic peptides, to work much harder and last much longer. However, there's a critical caveat.
Which is?
Neprilysin also degrades angiotensin II. If you only inhibit neprilysin, you risk a massive acute buildup of angiotensin II, which would be disastrous.
Which is why the combination with valsartan is mandatory. The ARB blocks the harmful effects of any lingering angiotensin II, while the neprilysin inhibitor boosts the beneficial peptides. It's the ultimate push-and-pull therapy.
It is a brilliant two-front war. Clinical trials showed that this combination provided significant survival benefits above and beyond what was achieved with ACE inhibitors alone.
So it's become a new first-line therapy.
It's rapidly becoming a preferred first-line therapy, often replacing ACE inhibitors entirely for eligible HFrEF patients.
The last drug mentioned is tolvaptan. What niche does this oral drug fill?
Tolvaptan is an oral non-peptide vasopressin V2 receptor antagonist.
So it blocks the antidiuretic hormone?
Right. Vasopressin, or ADH, causes the kidney to retain water. Tolvaptan works by blocking the V2 receptor, causing pure water excretion without significant electrolyte loss. Its niche is treating hyponatremia low sodium levels and relieving severe congestion and dyspnea in advanced HF patients who are refractory to standard diuretics.
A good short-term solution for a complex electrolyte problem.
Yes. But like diuretics, while tolvaptan offers acute relief and helps manage challenging fluid imbalances, there is no established long-term benefit on overall survival or disease progression.
What a deep dive. We've gone from a plant discovered to treat dropsy in the 18th century to a molecular mechanism that hinges on tiny ion pump inhibition, to a modern strategy built entirely around intercepting the body's own destructive feedback loops.
The central takeaway is that fundamental shift in philosophy. Digoxin was a mechanical assist, useful for strength and electrical control, but often toxic. The modern drugs, the ACE inhibitors, the beta blockers, the ARNIs, they are life-prolonging because they stop that maladaptive neurohumoral cycle that was silently driving the disease progression and heart muscle death.
And digoxin today is a surgical tool, primarily for rate control in the presence of atrial arrhythmias and heart failure, no longer the blunt instrument of first resort.
Exactly.
The success of modern therapy really lies in recognizing that chronic disease often results from the failure to downregulate acute, life-saving stress responses.
The complexity of cardiovascular pharmacology demands a multi-system approach. You have to manage the pump, the electrical signals, and the hormones all simultaneously.
Which brings us to our final provocative thought for you, the listener, to mull over. We learned that the most effective heart failure therapies work by inhibiting the body's own immediate, life-saving acute responses, the sympathetic nervous system and the RAS, because those acute responses are toxic in the long term. Given this unique insight into the difference between surviving a crisis and managing a chronic condition, where else in medicine might we be accelerating long-term decay by prioritizing the body's short-term overcompensatory reactions? What defense mechanisms are we currently letting run unchecked because they seem helpful in the moment?
Until next time.